In this video, we will show the surgical steps of the Dolench approach, suitable applied to the treatment of paraclinoid aneurysms. The paraclinoid aneurysms are a group of heterogeneous aneurysms located around the internal carotid artery, the anterior clinoid process, and the optic nerve. The Dolench approach has 8 steps that should be completed extradurally before attacking the aneurysm. This technique is as follows. At the beginning, we drill the sphenoid ridge, the anterior clinoid process, and the roof of the orbit until the periorbit is exposed. At this point, we move laterally to identify the foramen rotundum and make a drilling between the foramen rotundum and the apex of the orbit. In this way, the lateral wall of the superior orbital fissure is obtained in one piece. In this case, we drill the roof of the optic nerve until the nerve is totally exposed extradurally. Now, we are ready to move into the middle fossa. At the beginning, we move the microscope laterally to start separating the dura from the bone until we get the foramen spinosum. The foramen spinosum is expanded in order to get space to coagulate the middle meningeal artery. The middle meningeal artery is cut to get more space in the middle fossa. Anterior and medial to the foramen spinosum is the foramen ovale, which is also expanded to get more space behind the V3 branch of the trigeminal nerve. The dura is separated from the middle fossa to locate the arcuate eminence and the greater petrosal nerve. The petrosal nerve is separated from its dural attachment and cut to follow the canal of the petrosal nerve with a diamond tip drill until the internal carotid artery comes into view. The internal carotid artery is dissected from its surroundings using a microdissector in order to allow the introduction of a surgical putty into the carotid canal. This technique, used by Fukushima, allows a proximal vascular control if necessary. As a test, the surgical putty is introduced and after a while is taken out, and only a small part of it remains into the canal in order to get the proximal control in case of some emergency during the surgery. Now the extradural Dolench approach is complete. In the first demonstrative case, we will show a dorsal distal small aneurysm in a patient with a recent subarachnoid hemorrhage. The dura is open in a semilunar fashion and the sylvian fissure is split using the hypodermic needle and micro scissors down to the basal cisterns. The arachnoid tissue is cut until the basal cisterns are visible, as well as the internal carotid artery and the optic nerve. The aneurysm is now under vision, and we complete the dissection around the neck of the aneurysm. the dome is separated from the optic nerve in order to confirm the position of the neck of the aneurysm. Using a titanium Yashargil mini clip, the neck of the aneurysm is completely obliterated. A small piece of sponge is positioned between the nerve and the clip to avoid any damage to the nerve. The postoperative angiogram shows total occlusion of the aneurysm. In the second demonstrative case, we present a dorsal proximal true ophthalmic big aneurysm. We opened the dura in a semicircular fashion, and the sylvian fissure is separated using the hypodermic needle and the micro scissors. The dissection goes into the basal cisterns until the aneurysm comes into view. The dura over the optic nerve and the tip of the clinoid process is coagulated and divided. With the aid of a diamond tip drill, the rest of the anterior clinoid process is drilled away. The tip of the clinoid process is obtained in one piece. Underneath the clinoid process is the roof of the cavernous sinus. We injected fibrin glue to avoid any bleeding coming from the sinus. After, we cut the distal dural ring and the cover of the optic nerve to facilitate its mobilization. A temporary clip is positioned between the proximal and distal dural ring. Using a series of straight Yashargil clips, we obliterate the aneurysm. In this case, we use a second clip, taking care at the bottom of the exposition not to damage the optic nerve. We decided to use a third clip, and after then we puncture the dome of the aneurysm and apply negative pressure to be sure that no blood is coming from the dome of the aneurysm. Finally, we use the transcranial Doppler to confirm the patency of the internal carotid artery. The surgical putty used to have a proximal vascular control is taken out, and we put in place a small piece of surgical sponge. The post-operative angiogram shows a total obliteration of the aneurysm. In the third demonstrative case, we show a ventral type big aneurysm. In this case, the patient had a poor collateral circulation, and we decided to perform a prophylactic bypass. At the beginning, we opened the sylvian fissure in the usual manner until the aneurysm comes into view. We can see the turbulence of the blood through the wall of the aneurysm. We covered the dome of the aneurysm with a surgical putty, and we dissected the M2 branch of the middle cerebral artery using a colored thumb to separate this segment of the recipient artery. The radial artery was obtained from the left upper limb of the patient, separating all the collateral small branches and cutting the proximal and distal part of the artery. we should take care to get at least 20 centimeters in length of the artery. We prepare the radial artery with a solution of nimodipine and high pressure to avoid spasm. The last centimeter of the artery is clean of adventitious tissue, and the distal end is opened in a mouthfish fashion. The recipient artery is closed proximally and distally using temporary clips, and a small arteriotomy is performed using the hypodermic needle. We use a violet dye to make more visible the borders of the arteriotomy. The bypass is completed using 2 lines of 10-0 nylon sutures. Previous to this intracranial anastomosis, the anastomosis between the external carotid artery and the radial artery had been completed. After the anastomosis is finished, the proximal and distal temporary clips are retired and the functioning of the bypass is confirmed. After the bypass, we come back to the aneurysm area to coagulate, cut and separate the dura over the optic nerve and the anterior clinoid process. Using a high-speed diamond tip drill, the tip of the anterior clinoid process is resected. We get the tip of the clinoid process in one piece, and we injected fibrin glue at the roof of the cavernous sinus to avoid the bleeding coming from it. Now we opened the distal dural ring as well as the covering of the optic nerve. Now the aneurysm is ready to be clipped. We put a temporary clip distal to the neck of the aneurysm, and another temporary clip is positioned between the proximal and distal dural ring. We puncture the dome of the aneurysm and we apply negative pressure to collapse the dome of the aneurysm. Using a series of fenestrated ring clips, we will try to reconstruct the normal trajectory of the internal carotid artery. A first and a second ring clips are positioned, taking care not to open the aneurysm dome. A third clip is necessary to occlude completely the neck of the aneurysm. Now the temporary clips are retired and the patency of the internal carotid artery is confirmed using the transcranial Doppler proximally and distally. This is our final view, and the post-operative angiogram shows a total obliteration of the neck.